Good afternoon and welcome to today's webinar, Medicare 102. Welcome. My name is Tammy Cave and I am a management analyst and caregiver specialist with the Caregiver and Supportive Services Unit here at Fairfax County Area Agency on Aging. Before I introduce today's speaker, I will give a quick disclaimer and go over a few housekeeping items. Please note that today's presentation is not designed for broker or agent education. The slides for this webinar have not been distributed as the content is proprietary and intended for internal use only. For any inquiries regarding Medicare, please contact the Fairfax County, Virginia Insurance Counseling and Assistance Program, or VICAP. You can contact them directly at 703-324-5851. If your call is not answered, kindly leave a message, including your name, your telephone number, and a convenient time to return the call. This number serves as VICAP's intake line. Today's presentation is being recorded, and a link to the recording will be sent to all registrants 1 week from today. Additionally, please note that closed captioning has been enabled for your convenience. There is a Q&A button at the bottom of your screen where you can submit any questions you may have. We are going to spend a few minutes at the end of the presentation to address as many questions as possible. We will provide the VICAP contact information in our follow-up email after the webinar for any of your other questions that you may have. As you sign out, please take a moment to complete 2 brief surveys. Your feedback is invaluable in helping us to develop programs that are meaningful and engaging for our caregiving community. In addition to the Area Agency on Aging survey, you will also receive a satisfaction survey via email from VICAP and the Administration for Community Living. We thank you so much for your participation. And now it is my pleasure to introduce today's speaker, Mr. Bill Vaughn. Bill Vaughn has been a VICAP volunteer for over 8 years. He worked on Medicare issues most of his career, serving in government for 36 years, and was a registered lobbyist for the Consumers Union and also a publisher of the Consumer Reports magazine. Bill, please come online, and we thank you so much for being here. We are looking forward to your presentation today. Please take it away.
Oh, thank you. And thank everyone who's tuning in. If you were in the 101 presentation, there'll be some repetition, call it review today, but we're going to dig in a lot deeper into the very key question that people in Medicare face, whether they should join original traditional fee-for-service Medicare or whether they should join one of these companies like Kaiser or ARP United or Humana to get their Medicare services. That's a key question that we're going to dig into. If you missed the 101, we'll be going pretty fast. And if I lose you, I hope you'd go back and look at the 101. And to all of you, VICAP has a series of face-to-face live presentations at various libraries scattered around the county during the coming month, about 8 more or so of those. And if you can get the locations from our website, but if you have a personal question or we've confused you, urge you to come to one of those seminars and we'll stay and work with you as long as you're needed until your questions are answered. So who are we? Tiny little office in your county government, and a goal is to provide independent advice on the Medicare choices that you're facing. Where I have never, ever, and never will take any money from anybody trying to sell you stuff in Medicare. So no conflicts of interest. And that's so important because there's about 90 companies, almost all of them for profit, trying to sell you stuff. They make a ton of money, a lot of money when they sign somebody up. So the selling has been grossly aggressive. I gather some of you probably have gotten calls from some of these companies that you didn't ask for. You didn't call and say, hey, can somebody call me and explain this plan? If you get a call that you didn't ask for, hang up. They are violating the marketing rules. And if they're violating those rules, imagine how they'll treat you when you're sick and file a claim. So, and nobody should come to your door, and be very, very leery of anybody saying, hi, I'm from Medicare and I want to. Medicare almost never, ever calls you. There's a tiny chance it might be Medicare, but don't talk to anybody who says they're from Medicare or wants your Medicare number without a heck of a lot of proof as to who they are, because there's some real fraud out there, and be suspicious. This is like buying used cars. Be suspicious. These are the permanent staff, contacts, and good sources of information that I talked about last time. This Medicare and You handbook is really good. You can read it online at medicare.gov. You can order a hard copy. It may be good to have one hard copy in the office for reference. And it's cool because each year it has a what's new in Medicare. And Medicare constantly changing. It needs to. It's a $1.6 trillion program covering over 100 million Americans in Medicare and Medicaid. And so things are always happening. Now, this may not be real exciting to many of us many of us over 65 on Medicare, but an example, Monday, a major expansion of preventive care benefit under Medicare and Medicaid of free contraceptives. Again, not maybe top of your list, but think there's 9 million people on Medicare under age 65 because of a disability, and that might be of interest to them. There's this constant changing of what's covered or not covered as the science shows that something should be covered, or the science might show, that's not working, that's killing people, let's quit covering it. And the Medicare.gov website is a great place to go and see what's new. This publication is also good on what the benefits under Medicare are. Lots of preventive benefits. I don't know if you can see, but on these 2 pages, there's lots of little apples, like in an apple a day keeps the doctor away. Preventive care benefits under Medicare that I hope you're taking advantage of. And new things, acupuncture was about a year ago or so, year and a half ago, they started covering acupuncture for persistent lower back pain, 20 visits. That kind of information is in the Medicare and You handbook or the website, and is worth checking out. Again, today, key choices, and that's the big one. Original traditional Medicare, fee for service. I go to the doctor, she or he provides the service, Medicare, and I pay the fee. Or one of these companies, Kaiser, Humana. Should I get Part B? It's not always obvious. It is optional. You do have to pay for it. So should I get it? Should you get a Part D drug plan? And we'll suggest ways to save some money there. And a big one, place to save maybe tens of thousands over your lifetime, is how to get a good deal on a Medigap Medicare supplement. Again, same thing, right? Gap and supplement are the same interchangeable terms. And it's a place to save a ton of money. If you make a bad choice, you can change during this open enrollment period. I want to stress, we had a library event yesterday, and at least 3 people came up afterwards and said, and when's open enrollment for my Medigap policy? No, 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 no. The Medigap Medicare supplement market is private insurance regulated by the state of Virginia. It's not part of Medicare. It's not part of Medicare, and there's no open enrollment season on it. So you can't expect to change from year to year. For most of us, there's exceptions, but for most of us, a Medigap policy is a lifetime commitment. We'll talk about this more because it is a huge source of confusion. You need to make these decisions timely, or there's a late enrollment penalty. Government wants to get everybody into the insurance pool so that you know, pay premiums when you're healthy to pay for when you're sick. If you wouldn't get a fire insurance policy once the attic's on fire, you need to buy fire insurance before the fire. And same with health insurance. You need to get into the insurance pool early. And I stressed this last time, these Medicare drug plans and these managed care plans like Kaiser and change dramatically from year to year. If again, they're for profit, and think about it, if they're losing money in our county, they're going to change to make money in the new year. Aetna is leaving counties around the country where 500,000 people who had Aetna in this year won't have it in the new year, and they're going to have to make a change and a choice. Keep your eye on them because these companies can change in ways that can make what was a really good deal for you. You were a good shopper. You did what you should do. You picked the best value plan for you. In the new year, it could be the worst. It could bankrupt you. So you need to check each October, put it on the calendar, go to Medicare.gov and make sure these plans are still good for you in the new year. And making choices, we need the basic lingo. Medicare has 4 parts: A for hospitals, B for docs, C is the technical term for these managed care companies, and D is drugs. Thank goodness they matched D with drugs, huh? And there is no Medigap Medicare supplement part. These are private insurance companies. Everybody gets this wrong. Please help your neighbors. If anybody says, whoa, I've got this Medicare Medigap policy. No, you have a private insurance policy. There's some federal consumer protections, but not much, not much. Part A is hospital. You earn it through working 10 years. And it'll feel free because you don't pay a premium in your older years. And what happens is, you know, we're all paying that Social Security tax when we work. A little bit of it was moved over to the Part A hospital trust fund so that when you retire, you've earned that Part A without further payment. You have paid for it. It's just you prepaid. Good benefit, but look at that bottom paragraph. The first day deductible before the benefit kicks in is $1,632, which is the average cost of a hospital stay in America. Wow. And that can happen to you 3 or 4 times in a year because the benefit's based on a 60-day admission cycle. So that if I had to go to the hospital today, get hit by a bus leaving here, I'd owe $1,632. I'd owe nothing for the next 59 days. And then some copays, pretty big copays, but copays kick in on day 61. In this example, as you can see, on the 4th day, I go home. I'm out of the hospital for 60 days. If I then have another bus hit me on the 65th day, maybe I need a seeing eye dog or something. If another bus hits me, I'd owe another deductible. And that could happen if you're really unlucky 3, 4 times a year. And to fill those kind of financial gaps is why people get these Medigap Medicare supplement policies. The B is doctor stuff, voluntary, optional. You don't have to take it. This year, the premium's about $175. We'll know the new numbers on all these numbers I'm using today are for this year. We're about to get the new numbers, and most of them will be a a few bucks higher because of medical inflation. Lower income won't pay 175. They'll get some help. Higher income are asked to pay more because the 175, while it's a lot of money, is one fourth the cost of this insurance product. The Treasury, which means what? Our kids and the taxpayers are paying three-fourths. It's a good benefit, pays 80% of most stuff, 100% of home health nurses visits. And doctors are seeing Medicare patients. There's some, nobody's seeing Medicare. It can be hard to find a doctor who's got openings. And that can be a real problem in GPs and so forth, and particularly psychiatry. But 90% of docs are seeing Medicare patients. And what you want to do is find a participating doc, which is almost all of them. That means they take the Medicare fee schedule as payment in full. If they're non-participating, they can charge 15% more. And what the heck? Why pay that? And avoid the guys and women who have opted out. Serious problem in psychiatry. About 30% of psychiatrists, they're so busy, they're in such demand, they just say, the heck with it, I don't need the paperwork of insurance, pay me cash. And so if they've opted out, you're all on your own. D is for drugs, and these are voluntary, you don't have to take it. Again, private companies, you've got 14 choices in our county, and was a crummy benefit for years and years. In the last couple of years, it's become a great benefit. First, the cost of diabetes drugs limited to 35 bucks. They used to be all over the place and up to the hundreds of dollars. And look at the third paragraph. In the new year, once you have spent $2,000 on prescription drugs, and if the drugs are on the formulary, the list of drugs the company covers, and you see that on the Medicare.gov website, once you spend $2,000, you are totally covered. No more expense. And I'm really excited about that. As I said in the 101, I worked on a case where a person had $840,000 in pills and owed 5% of the cost under the old law, $40,000. Now the person is protected at $2,000. It really has become a good benefit. Part C, managed care, Medicare Advantage. C is the way to get your A, hospital, your B, doctor, and usually we recommend get one that covers the D, drugs. The formal term for these things is Medicare Advantage. 21 years ago, a bunch of people in Congress wanted more of us to join them. The previous name was kind of silly, and they call them Medicare Advantage. Whether they are an advantage or not will depend on the quality of the plan you pick, your health, your luck. They could be a disadvantage for you, and that's what we're going to talk about today. I am not anti-managed care. Some people say, "Oh, you seem very critical." They spend billions telling you how wonderful they are, and they've got a name called Medicare Advantage. As a consumer advocate, you should hear that they're not always an advantage, that there are downsides, there are pros and cons. And since nobody's spending billions telling you about the cons, I'm going to mention a few, okay? But that doesn't make me anti-managed care. It makes me suspicious, but not anti, okay? And started basically in the 80s, has become quite popular. This year in the nation, 51% of Medicare folks are in these plans. In Virginia, we think it's a lot less, maybe in the 20%. And to join one, you have to join Part B. You got to pay that Part B premium. Although some plans advertise they'll even help pay part of the Part B premium. And often you're asked to pay a premium to the plan. We have a lot of zero premium companies in our county you can choose between, but some cost $100 a month or more. Um, and this is, again, part of what you're shopping for during open enrollment period or when you first start Medicare. And maybe this slide helps. Original Medicare A and B, there's an agency, Centers for Medicare and Medicaid Services, up in Baltimore, has about 6,700 staffers nationwide for this huge program. They contract with usually the Blues, Blue Cross Blue Shield, to do the actual administration work, and they set prices. After studying how much a procedure should cost in a hospital or how much a doctor needs to do X, Y, and Z, they set a fee schedule. And it's a pretty direct involvement between the government and hospitals and doctors. The drug benefit, the government contracts with a group of companies like Express Scripts, and you deal with them. You pick the plan you want, and there's that intermediary. In Medicare Advantage, the government is less directly involved. The government says, hey, Humana, or actually Humana says, hey, government, I'd like to participate. And the government gives money to Humana, and Humana then works out deals, contracts with different hospitals, with different docs, and with different drug companies. There's that layer in between that you don't have in the hospital and doctor part of traditional Medicare. Capiche? What the plans do is they form networks. They contract with a group of hospitals and doctors in a county. And for example, Humana might say to Inova, oh, we're going to bring you 30,000 customers. Give us a price break. And they can get some savings that way as a volume buyer. The danger, of course, is that maybe the network isn't very strong. The HHS Inspector General was complaining, I think last summer, about a plan in upstate New York that had contracted with 14% of the area's doctors. That's 1 in every 7 doctors is in this network. Is that a good enough network? That'd be for you to decide, but the Inspector General was worried. The benefits and the cost sharing in these plans may differ slightly from traditional Medicare, but the plans have to offer you catastrophic protection. After you have spent a certain amount on copays and deductibles to their network of doctors and hospitals, you're totally protected. And that's part of what you shop for, is how low or how good a catastrophic protection cap is. But in these plans, you do have copays and deductibles as you go through the year and see doctors and stuff. And there's no Medigap policy to eliminate that. So if you're sick, you're probably spending more in these plans than you are in traditional Medicare with a good retirement plan or with a good Medigap policy. But because they can get savings, they do offer extra stuff like hearing aids and eyeglasses and dental cleanings and gym memberships. One company, a couple companies do. Ask tough questions about that extra stuff. A lot of these companies don't particularly seem to deliver those benefits. And change, the government's going to require the companies in the middle of the plan year, middle of next year, if you join one of these, to send you a letter reminding you that you have extra stuff and maybe you're not using it because it's not being well used. But when people have tried to use it, they have run into problems on quantity limits or dollar limits or whose approval you have to get treated and so forth. So if you want to go the managed care route, ask tough questions about the extras. They're not free. I don't, you guys ever see one of those ads by Joe Namath, the old quarterback? Used to sell pantyhose, I believe, but he went on to sell managed care plans. And you listen, and it sounded like you could get everything. You could get somebody to come into your house and brush your teeth. It was quite a list of things. Probe on those promises. Probe on them. They may be exaggerated. This is such a growing part of Medicare. It's, I think, important to understand how they're paid. And this is very simplified. But Medicare figures out the average cost of treating somebody my age in Fairfax County, and it rounds out to about $10,000 a year. We seniors get expensive, don't we? $10,000 a year to keep me healthy. And if I join a plan, Humana, let's say, I'm considered a capitated payment. The government says, Humana, you've signed Bill up, and for his head, for his per capita, we're going to give you a check for $10,000. And you keep him healthy for the rest of the year. That he's become your problem. Capitated payments. Well, to participate, these plans then have to bid to serve in Fairfax County. And if the bid on the left side of the screen, if the bid comes in above 10,000, you and I would pay the extra in higher premiums. If the bid comes in below like 9,000, the company doesn't, it's gotten 10,000, right? It's bidding 9,000. It doesn't keep that extra thou as pure profit. It gets some extra profit, but the government says, hey guys, you got to give most of that back to people in extra stuff. And that's where all this free extra stuff is coming from. Now, please ask yourself, how does a company, most of them, not Kaiser, but most of them for profit, paying their stockholders dividends, most of them paying their CEOs in the tens of millions, as far as I can see. How do they come in below the average cost of Medicare? Great question. It's really the heart of the issue here. We Americans have the world's most expensive healthcare system by far, almost double the average of other industrial nations. And I think anybody can find a way to get savings in our healthcare system. And the absolute key is, are they good savings or are they bad savings? Are you getting that extra eyeglasses because the company had good savings, or did they have bad savings? And I list some examples here of good and bad. I mean, good is making sure I have my COVID shots and my shingle shots and my flu shots, and that I'm taking my blood pressure medicine so I don't have a stroke, or if I'm a diabetic, I'm got my sugars under control, and those are good savings, right? Those are the kind of things that we want a plan to do. Or bad savings, and this is what's sad. The good savings take some work. They're kind of hard to do. You got to work with the patients. Bad savings are pretty darn easy to achieve, and but that would be discouraging people who get sick from staying in the plan by maybe having only one chemotherapy doctor in the area, or limited chemo drugs, and making people wait for hip and knee transplants surgery, denying appeals. Those would all be, in my book, bad savings. And the goal for you as a consumer is pick a good savings plan. And that is not easy. The government has a quality star system. 5 stars is tops. And it's based on data. It isn't just, oh, yeah, I like the deodorant my doctor uses. Yeah, it smells good. No, it's hard data on the quality of the work they do. And 5 stars is tops. And the big problem is Fairfax County has become Lake Wobegon. All our plans in our county are above the average of 2.5 stars. In our county, the average is 4.1 stars. If you join one of these plans, avoid the guys below 4 stars. They are below average quality in our county. If they're in the threes, run. They're having trouble answering the phone, in our opinion. This is our opinion. Let me go back a second. Think about it. Think about this choice you've got between fee-for-service and these managed care companies as a choice between two really bad payment systems. And the question is, I'm sorry, I don't mean to laugh, it's sad. But the question is, when you're 90 and frail and maybe sickly, which one can you handle best? In fee-for-service, the incentive is to do more. The more the doctors do, the more they get paid. And when I was a young man, I worked on a case for the government of a hospital chain in the Carolinas that had given bonuses, incentive payments to its surgeons and OBGYNs to do C-sections on women. Guess what? The C-section rate in those hospitals went through the ceiling. Think about it. If a street thug walked down the street and slashed women's bellies open, we'd put him away and throw the key away too, right? This hospital chain got a reprimand, told don't do that anymore, and paid a fine. But that's the incentive in fee for service, to do too damn much. And some of that stuff is just plain bad for you. And the government spends a lot of its time making sure there isn't overutilization or overuse. And in Medicare Advantage, the incentive is completely switched. You've given the company a hunk of money. The less they do, the more profit they make. And can you handle that well? Again, as a young man, the craziest case I worked on was a guy down in Florida started an HMO, and he got quite a number of people enrolled. And so the first of the month, the government sent him a check for 36 million to pay the hospitals and doctors and drug companies that the company had in their network that people were using. Well, one month, this gentleman quit paying the hospitals and the doctors and the drug companies and the wheelchair guys and just kept the money in the bank. The people didn't notice. The doctors were starting to get grumpy. But the next month, another check for 36 million. He took the two checks, 72 million, and went to Venezuela. This was back when the Venezuelan government was kind of friendly. The FBI, 3 times working with the Venezuelan police, were going to raid the hacienda he was at. 3 times. The night before, somebody talked and he fled. He finally went to Spain and married a female relative of General Franco, and the Supreme Court of Spain, in its wisdom, refused to extradite him. 72 million of your tax dollars stolen in this HMO operation, and you get the idea. The less they do, the more money they make. And if this guy did nothing, he got 72 million of your dollars. So that's what the government spends its time on in Medicare Advantage, is making sure that these plans do deliver care and services you need. And that was a long anecdote. I don't want to run over here. So it's how am I doing time wise?
You're doing good. You're doing
Okay,
really fine.
we're doing okay. Okay. Let's switch back to traditional Medicare. If you don't have a good retirement plan, you want to get one of these Medigap Medicare supplements to eliminate that big 1632 hospital deductible. These plans, there's about 50 choices in our state, cover the financial gaps of A and B, not D, not drug. In drug, you're going to have copays and deductibles. Fill the financial gaps of A and B of the things Medicare covers. Medicare doesn't cover eyeglasses. Your Medigap plan will not cover eyeglasses. And once again, there's no open enrollment in these guys, right? These are private insurance. These are not part of Medicare. A good, a comprehensive one at age 65 will be about 120. If you're shop well, which we'll help talk about in a minute. They go up as you age, and by the time you're 80, you're looking at 300 a month or so. So it's a lifetime commitment, and it gradually gets a bit more expensive, but so does healthcare. Lower income can get help. If your income's below these levels, please check the Medicare and You Handbook for help. If you ever hear a neighbor say, I can't afford a prescription drug because of the copays, have them call us. I bet you there's help. And 14,000 people in our county haven't signed up for what can be a big improvement in their life. And higher income people are asked to pay more than 25% of the Part B and D premiums. And this gets confusing. Oh, I'm sorry. The numbers on this chart, we'll see new numbers momentarily with inflation. I bet you we're probably looking at 106,000 and 212,000 before this impacts you. This being, you see that term up at the top of the screen, IRMA, like the girl's name, income-related Medicare adjustment amount. Say that's my favorite Jeopardy question. What does IRMA mean? Between the time the IRS knows what your income is and tells Social Security, there's a 2-year lag. And so you're facing this in 2024, if your income was above this 103 level, you were asked to pay 35% or 50%, and of course, people can say, that's crazy, because we've had a life-altering event. You can see the underlined term. If you've had a life-altering event where a spouse died or you retired or something like that, you get this form from Social Security or on their website and file it, and the premiums will be adjusted for you. This does not count a big surge in financial income, like you cash out all your CDs in 1 year. Great place for tax planning. Spread it out, and you can avoid being pushed into a higher bracket for a year. A lot of stuff Medicare doesn't cover, particularly dementia care. You have one presidential candidate has talked about we need to get more home health aides out to people's houses because that's incredibly expensive to hire a person to watch a relative who's wandering. But again, while it's nice that we're starting to talk about this issue, the solution isn't tomorrow morning. You need to be aware of dementia costs and just generally rising medical expenses. Medical inflation has for 60 years been higher than the rate of general inflation. That means more and more comes out of your pocket and can't just go for grandchildren's Christmas presents. Throwing a lot at you again. You can look at this page and just make sure you know what these things are. And then on to choices. you've got these two roads that you can pick, original, traditional, fee for service, one of these companies. And if you choose original Medicare, you've earned Part A, probably want to get Part B if you don't have a good company plan. And D, you'd want to get drug coverage, you'd want to get a Medigap. Or you can just say, hey, Humana, I'm going to let you take care of it. I'm joining a Humana plan that covers drugs, and I can't get a Medigap policy, and take care of me. Can you switch? We stressed this in the last talk. It is, I think, the biggest problem in Medicare is that after you've been in one of these managed care plans for a year, it can be tough to get a Medigap policy. And we talked about this example that you sign up at 65 for traditional, you buy a gap policy, give up the gap policy because you want all those dental benefits that the managed care plan is advertising. You get really sick in your 70s or 80s, and you say, I want to go to a hospital that is not in the network of my plan I've joined, because those people know how to treat this kind of terrible disease. You're not going to get a Medigap policy at an affordable rate at that point. That is the big problem. So yeah, you can switch back and forth during open enrollment period, but don't plan on being able to keep a Medigap policy. That is so important to understand. There are exceptions. You can go to the Medicare.gov website and look under guaranteed issue rights. Guaranteed issue rights for Medigap policies. And there's a couple pages of exceptions to what I've just said. But for most of us, most of our lives, a Medigap policy is a one-time commitment. And pros and cons, there's strong pros and cons on both sides of this original Medicare managed care plan. The pros in fee-for-service is a lot of freedom of choice. Go to 90% of the nation's docs, 99% of the nation's hospitals, makes travel really easy. No skimping on care, just in fact, you got to beat people off with a stick sometimes. So that can be bad, but no skimping on care. And if you enroll in a good Medigap policy or have a good retirement plan, like federal workers, when you're sick, you have basically no costs. You are home free. The pros in managed care is a little simpler. You don't bother with Medigap and let the company take care of your drug use. It avoids overuse. It's good to have managed care. People who go out and have, oh, I have 2 or 3 doctors. Yeah, they tell me different things and I'm taking different pills, and you don't know how those interact. They could interact to kill you. So having managed coordinated care is a good thing. By making savings, these managed care companies can offer you extra stuff, which is cool. And because you're at the first of the month, when you're paying premiums, you pay your Part B premium and maybe pay a premium to the Medicare Advantage plan, but you're not spending money on a Medigap policy. So you're probably at the first of the month not spending as much money. And as I've said, these plans offer catastrophic protection at a certain point, somewhere between, it varies widely, but between 3,000 and 14,000. Once you spend that much out of pocket, you get protection. You don't pay more. Cons of, on the left, Medicare, traditional Medicare, with the Medigap policy, it could be more expensive than managed care. Care's uncoordinated, which, as I said, can be a bad thing, and a little more complicated, a little more shopping. The cons in Medicare Advantage is by channeling you into a network. If the network is weak, doesn't have maybe the fanciest doctors in town, um, that can be kind of a denial of care, can't it? And if the best place in the world is to treat what you got is, say, Mayo in Minnesota, and Mayo's not in the network, you'd pay the whole bill. And that could be life-threatening. A doctor that you've used all your life might not be in the plan. Or what's scarier is these plans can drop doctors in the middle of the year. One prominent company has done that. That would be annoying. You sign up for the year and they drop a doctor mid-year. What the heck is that? Traveling can be a little tough. And the academic research shows that as we get older and have complex illnesses, a lot of us would like to leave these plans. But of course, at that point, we can't get a Medigap policy. And those are big cons. I can't get a Medigap policy is that first long paragraph. But the plans change from year to year. As I said, Aetna's dropping 500,000 people this year. You got to watch them. You got to, every October 15th, get on the website and make sure it is still a good plan for you. We put this chart together. If you're very healthy, Medicare Advantage is probably an advantage by maybe a couple $1,000 because you're not paying Medigap policy premiums, right? And you're getting extra stuff. That's really cool. If you get sick, it reverses. And in the right-hand column on this chart where it says copays, deductibles, 7,500, that number can be higher, it can be lower. That's part of what you shop for. But if you pick the number we picked, you can see that when you're sick, these plans can be a problem. If you want to go the Medicare Advantage route, pick one that covers drugs, in our opinion. Check that the doc you really care about is in the network. Don't rely on the websites. They have been very inaccurate. The Inspector General was grumpy at one famous plan in our country that had about a 50% error rate on the doctors it said were in its network. That doesn't sound like an error rate. That sounds like fraud to me, but check with your doctor's office. If I join X, will you still see me in the morning? Go for the higher quality stars. Avoid folks below 4, in my opinion, and probe hard on the extra benefits. Part B, 3 big scenarios that we talked about last time. You're turning 65, you don't have health insurance, get it around your birthday, or late enrollment penalty for the rest of your life. Special enrollment period, I think, as most folks are in this boat. You have coverage because either you or your spouse is working, actively working, not in a retirement plan, but actively working for a company of 20 or more. You can delay joining Part B and Part D with no late enrollment penalty. You can join Part B anytime you want. Once you quit active work, once you quit or the spouse quits, join Part B within 8 months, no late enrollment penalty. After that, it starts accumulating fast, okay? And then if you have a good retirement health plan, cool. Just be sure it doesn't go bankrupt during your lifetime. You live to 110. If they go bankrupt and you need a doctor, you're going to have a very big late enrollment penalty. And I want to give a call out to a really neat publication by Washington Consumer Checkbook, sort of a local consumer report magazine, and a real call out to any federal workers on the line. One of the local congressmen, Jerry Conley, is having the guy who writes this book at a presentation on Saturday, November 16th from 10 to 1 in the Government Center near Fair Oaks Mall. And the author of this will be there. He's a really cool guy. And the different plans in the federal retirement system will have literature there and people that you can ask questions to. It's a very good service that you might want to check out. Or you may have a retirement plan, bottom paragraph, that costs you an arm and a leg, and Medicare is cheaper. You can get really good care from Medicare and dental insurance and all for under 600 a month. Why pay your boss a fortune? Um, Talk to your HR departments before you change things. If you have health savings accounts or COBRA, maybe Google Medicare and COBRA, Medicare and HSAs, because there's some complications there that could screw you up a little bit. Check it out. And drug coverage, if you don't have what's called creditable drug coverage, coverage is good or better than the Medicare package, Part D package, get it, or when you need pills, you'll have a late enrollment penalty. And a lot of people say to us, oh, I don't need Part D. I just take one little generic and I get it from Walmart for $5. There's a zero free, zero premium plan you can join in our county this year and next year. And by enrolling, you prevent any late enrollment penalty and you have insurance. You don't know when you might be diagnosed with some horrible thing and have, like that one example, I had 840,000 worth of prescriptions. So you want insurance. And if you're taking a lot of pills, this is really easy, folks. Go to Medicare.gov, you put in your zip code, you put in the pills you think you'll be taking. A map will come up showing you all the drugstores near your house. You pick 4 or 5 of those just to get price comparisons. The plans will rank. The 14 plans will be ranked from lowest total cost to highest. And then you can get detailed information on how those drugs are priced and the quality of the plan and all that sort of stuff. And you can enroll online. And I tell you, if you don't take more than 5 pills, this is a 10-minute process. So go for it. And keep your eye on them. They change. And Medigap, again, pretty easy to shop for these. If you don't have a good retirement plan, like federal workers or county teachers, and if you don't have one of those plans, you'd want to fill those financial gaps. And 35 years ago, there was a lot of fraud in this sector. A lot of tinky little, tiny, ticky little differences between plans, and people were being sold 20 different policies. I kid you not, 20 different policies to fill the different gaps. And it was crazy. Congress said, standardize the plans that you sell. And there are 8 standard plans. And G is the most popular, we think, because it covers the most. It covers everything except a Part B deductible, which this year is $240 that you pay before Part B benefits start to kick in. But G plan would cover everything else, plus some travel expense that Medicare has nothing to. Medicare's no good overseas, with tiny exceptions. So G, and all Gs are identical. No G offers more than any other G or less. They're identical and they have nothing to do with your health. I can't stress this enough. They are bill payers. They're just cutting checks for that 20% that Medicare didn't pay. So why not get a good value, low cost plan? And the best time to buy these things is after you're 65 and in the 6 months after you start Part B. All 50 companies have to sell you their products with no medical underwriting. I forget whether I did this last time. It's kind of gross, but this is the back of my hand, and there's at least 4 to 5 different skin cancer operations in the back of that hand. If I tried to buy a Medigap policy at my age outside that 6-month window, they'd say, Bill, We're not going to cover your skin issues. We're not, you may have a proclivity to cancer. We're not going to cover cancer. Or sure, Bill, we'll cover you. That'll be $10,000. They will medically underwrite you. In the 6-month window, they can't do that. And super easy. You go to our Bureau, you could just Google Virginia Bureau of Insurance Medigap Guide. And what'll come up is a electronic version of what we used, I wish we still did, but we don't. We used to get till last year a print version of the names of the companies down one side, the plan models across the top, and the prices. Look at 2 or 3 of the cheapest models. There'll be a contact number you call, and if you're in the 6-month window, you're home free. It's done, and you will have saved. Look at that website. The variation among plans for an identical product can be $1,000 a year. It's crazy. It's absolutely crazy waste of money if you buy a high-priced plan. So shop, save you money all the rest of your life. And last points, how are we doing time-wise?
5 to 1, 5 minutes to 1.
5 minutes?
So we'll scoot this up and then, anyone we can't get to, we'll have them call you.
Okay, yeah, any questions we don't get to, please call VICAP. I'm gonna just stress, pay attention to the congressional budget debates. Remember I said Part A is prepaid benefit because a little bit of that Social Security tax was moved over and put into the Part A trust fund? Well, medical inflation's like this, I can't do that. General inflation's like, there's a gap. And the trust fund is running out of money because medical inflation inflates faster than the taxes going into it. And so you will hear, oh, Medicare's going bankrupt. No. It won't be able to pay all of its bills, the full amount of its bills around 2035, 36. And so some changes need to be made. Our entire lives since Medicare started, Medicare's been going bankrupt. Oh my God, it's going bankrupt. It's about to fall off a cliff. Never happened. It's not going to happen. If Medicare didn't start paying all of its bills, I bet you half the hospitals in this country would be bankrupt within the year. It's not going to happen. But we need to make changes. There are 3 ways to make the trust fund valid, right? Raise taxes, not very popular. Cut what we pay hospitals. Well, at a certain point, hospitals are going to say, oh, here comes another senior, I don't know, or they'll put us in the shoddiest rooms in the hospital, or they won't treat us as well as if we were a full paying customer. And that's not good to have a shoddy hospital system. Or they'll say, hey, beneficiaries, you pay more. Instead of $1,632 for the first day, how about $1,632 for the first 3 days? That's why it's important to pay attention to this coming debate. There's changes that won't bother you very much, and there's changes that can really hurt you. It's coming. Pay attention. It's a great question to ask your political types as to what their position is. Let me shut up and take questions.
Okay, well, Bill, thank you so much for the presentation and for sharing your expertise with us. I believe the information you provided today is going to be very beneficial for our audience. We are going to go ahead and move into taking a few questions. Let's see, to start off, someone says, my husband retired with the government. Should we purchase long-term care insurance if we plan to buy Medicare B and Medicare Advantage?
You've got to get B if you're going to do a Medicare Advantage plan. That's part of the deal. Long-term care insurance, we don't particularly get into, but just following this sector as a person who's interested, be very careful. There have been bankruptcies. There have been companies that have doubled, tripled the premiums. They miscalculated how much of this people were going to need. And there's some states have protections. I'm not sure if Virginia does, where if you're going to double the premium, you've got to give people the option to say, well, instead of 200 days coverage, I'll take 100 days coverage, or scale back the benefit. But this has been a very, very troubled market. The insurance companies have not done a good job estimating their costs, and be careful.
Okay. Next question, for monthly Part B premiums, is there assistance for lower income individuals, or is it just Medigap? Are the insurance plans available by county only, or is it by state?
Medigap is certainly, well, I'm sorry, it depends on the insurance company. They tend to be statewide. They tend to be nationwide, most of them, but there are some very local ones. There's some where you got to be a member of the Mennonite Church, for example. Ask the different companies, but I'm so sorry. Senior moment. I forgot the first part of the question.
Oh, for monthly Part B premiums, is there assistance for lower income individuals, or is it just Medigap?
There is something called MSP, Medicare Savings Program, which again, Medicare.gov, or just Google Medicare Savings Program can help you, or LIS, Low Income Support, which helps with the copays and deductibles in drug plans. And it's significant. I think the slide showed for a single, if you're around 20,000, there was help. If you're a couple, it's getting close to 30,000, there's help that can make life a lot easier. Please check those out, and they're pretty easy to apply for. You do it through our county Medicaid office, 703-324-7500. Or if you're looking for help with the drug benefits, you do it through Social Security offices.
Okay. And then you mentioned Aetna leaving Medicare Advantage. However, there is still an Aetna option available for 2025, which is more costly, right?
Thank you. Thank you for clarifying. In the nation, in several big states, Aetna is leaving the market. It has not left our market. I meant to use that as an example of these are not always guaranteed to stay in Virginia. And good news, if a plan leaves Fairfax County or the state, you have a guaranteed right with no medical underwriting to move to a new Medicare Advantage plan, or some of that right extends to the Medigap field. So take a look at that, guaranteed issue rights for Medigap policies. But my point was, these plans change fairly dramatically. Aetna is not in Virginia particularly, so not changing very much. But look at it. Look how it has changed.
Okay. And then if I choose traditional Medicare, what are my options for things like dental, glasses, etc.?
Again, our Bureau of Insurance, I've only been a volunteer 8 years, but I'm kind of impressed. I think they do a good job of making sure the rate increases aren't too big and all. And they have a list of dental and vision companies that they've looked at, and the company isn't, in the Cayman Islands and hasn't been cheating people too much and is relatively honest. And that's a nice list. I would go to their website, Virginia Bureau of Insurance, their website, and work off of that list. That'll give you the contacts and how to reach these companies, and get a couple quotes and go from there.
Okay. And then would you say that the Fairfax County Cigna plan is a good option versus a Medigap plan?
Thank you for asking the question. I think many people, county employees, county retirees, not school teachers, county retirees could do better with a Medigap policy than they would with a county plan. Thank you for asking the question. The county health plan is great during your working years, really good. But in retirement, check it out. You may find that there'd be a much better deal for you. Check it out. Good
Okay.
question.
And then if you have TRICARE,
If I said it wasn't as good, they might turn the lights off here in the room. So I don't want to insult the county. The county does a good job,
Yeah.
but the retirement plan, be careful.
Okay. And then if you,
Tammy, we're at time. Can you,
okay.
we'll go ahead and have everyone call us for the other questions.
Okay. So we want to thank you, Mr. Vaughn, for being here today. This is the end of our program. We had a lot of information to share. So if you all do have more questions, please call BICAP directly at 703-324-5851. Our next webinar will be on Wednesday, November 20th at noon on family caregiving and managing chronic diseases. In this session, we'll educate family caregivers of older adults and people with disabilities on how to best manage chronic diseases like high blood pressure and diabetes. We will explore advice on how family caregivers can overcome challenges in the management of diseases. Thank you all for taking the time to join us today with your busy schedules. We really appreciate it. Again, before signing off, please take a moment to complete both of the surveys that we've shared. We look forward to seeing you at our next webinar. Have a good afternoon. Bye. Thank you.
Thank you.